Thank you. I'm delighted to here today to present to you at the International Population Data Linkage Network Conference, even though it's virtually, and my presentation, Association between Optimal Combination Pharmacotherapy and Survival After Stroke, a Registry and Pharmaceutical Dispensing Study. Hi, I'm Monique Kilkenny. I'm an Associate Professor and Head of the National Stroke Data Linkage Program within the Stroke and Ageing Research Group at the School of Clinical Sciences at Monash Health, Monash University. I'm presenting this today on behalf of my co-authors listed on this slide. Prescription of medication, multiple classes of medications, is recommended in Australian clinical guidelines for stroke, especially for ischemic stroke and transient ischemic attack. This is to prevent further vascular events. These medications include antihypertensives, lipid-lowering medications, and antithrombotics. Research on the use of these medications after hospital discharge has been limited to mainly self-reported methods, such as in clinical trials or cross-sectional surveys. Evidence for individual medications has shown that initiation at discharge improves outcomes, especially survival. If you are discharged with antihypertensive medication at discharge, you have improved survival of around 0.78, has a rate of 0.78. Antithrombotics, 0.72, and lipid-lowering medications, 0.84. So my question today is, does risk of all-cause mortality differ based on the number of classes of secondary prevention medication supplied within 90 days of hospital discharge? Our aim of this presentation is to determine the association between optimal combination medication treatment, supply of antihypertensives, lipid-lowering, antithrombotics within 90 days of hospital discharge, and survival up to 1 year after ischemic stroke or transient ischemic attack. The data I'm using today is from the GP stroke cohort, and this includes data from the Australian Stroke Clinical Registry from 2010 to 2014, and this was linked to the National Death Index, as well as the Pharmaceutical Benefit Scheme, which is the medications in Australia, and the Medicare Benefit Scheme, which is the doctor visits. So we nearly have full coverage around Australia, except for, so we've got the Eastern Ball, which includes Queensland, New South Wales, Victoria, Tasmania, and Western Australia, but not Northern Territory and South Australia. So we have nearly 20,000 patients from 25 hospitals and over 2.5 million pharmacy records in this analysis. The definitions we've used for this is the anatomical therapeutic chemical, which is used to classify the medications. So you can see on this slide for antihypertensives, we use CO1 to CO9, antithrombotics BO1, lipid-lowering C10. And the exposure that we used for this presentation is the number of classes of secondary prevention medication dispensed within 90 days of hospital discharge. The analysis include only first-year events of ischemic stroke or transient ischemic attack, and we excluded patients who had died within 90 days of admission. We used Cox regression for this analysis to determine the association between the optimal treatment, 1, 2, 3 medications, from 90 days to 4, 55 or 1 year survival using landmark methods. All the analysis were adjusted for sociodemographics such as age, sex, socioeconomic position, as well as clinical characteristics, the stroke type, and the discharge destination. So this is a flow chart of the data. So we had nearly 18,000 patients, 95% were linked to the PBS. We excluded those deaths in 90 days and also the hemorrhagic strokes as well as undetermined strokes. So we were left with around just under 8,500 first ever ischemic or transient attack patients. And of those, 5% received no medication. 1 in 10 were provided 1 class of the medication. 28% were provided 2 classes of medications, and 1 in 2 were provided optimal treatment, which we classified as 3 classes of medications. So you can see in this slide here that the supply of medications varied. So in the first column is we had 439 had 0 medications. One medication was 921 patients. And then you can see how it's divided up between the classes. So for instance, 51% had only lipid lowering, 26% antithrombotics, and 22% antihypertensives. And then you can see the combinations of 2 medications where they include antihypertensives plus lipid lowering and so forth. So it did vary across the classes, the number of medications. What are some of the patient factors associated with optimal medication adherence? So if you can see here, the older you were, if you go across the slide here, the older you were, the more likely you receive 3 classes of medications or optimal treatment. There was no differences within sex. Females tended to have less likely to receive classes of medications. If you looked at previous medication use, you can see here that patients who were prescribed these medications previously were also more likely to be an receive optimal treatment or receive 3 classes of medications. When we look at some of the acute care factors and optimal medication adherence, we can see here those patients who were discharged to the community with a care plan, if they had a care plan, they're also more likely to receive 3 classes of medication or optimal treatment. So if they received no treatments, around about a third had a care plan, whereas half of the patients with optimal treatment actually received a care plan as well. And you can also see if the patient were more likely to go and see their primary care physician, they're also more likely to receive 3 classes of medications. And also if these were prescribed by their specialist physician, they're also more likely to receive all 3 of these medications. So looking at the survival curves, you can see we're looking at all-cause mortality and optimal medication adherence. And you can see we have, and the bottom line here is in purple is 3 classes of medication. So you can see that there was a difference in survival. The more classes of medication, the better survival. If you had no medication, you had worse survival compared to 1 class, 2 class, and 3 class. And all these models were significant, and they were adjusted for age, sex, socioeconomic position, stroke type, and discharge destination. We have similar survival curves for cardiovascular mortality, and you can also see the purple line here, that 3 classes had better survival than the green line here with no medication. And they're also adjusted for the same factors. So what are the strengths of this study? The strengths of this study, the eligible cases were based on the clinician diagnosis, which is held in the OSCA, that we have captured the majority of secondary prevention medication usage. We've got a very large sample size with 2.6 million. The limitations is we actually don't understand whether the patient actually took the prescribed medication, and we've no information about whether a patient received aspirin over the counter in the pharmacy. And we have no data also on comorbidities or contraindications and side effects. And in future studies, we'll have some information on comorbidities. So in conclusion, patients with stroke or TI who have optimal treatment, who receive 3 classes of medication within 90 days of admission, had a greater 1-year survival compared to those who received no medication, 1 class or 2 class. But we need further research is required to understand the reasons for suboptimal medication treatment. In the future study we're undertaking at the moment, we'll actually be able to understand, we'll have information from the registry linked to admissions records and also the emergency department records to capture the comorbidities as well as aged care data. And we also will be able to link to a survey data where we'll have self-reported adherence to understand what the patient is saying, whether they're adhering to the medication. I'd just like to acknowledge the Australian Stroke Clinical Registry and the Florey Institute of Neurosciences, and funding from the NHMRC for me, and just to let you know, this project was funded by the Stroke Foundation. Thank you.